Greetings, folks. So we're continuing to define what abnormal is in terms of psychological issues. And so let me offer this to you. There is no difference in kind of behavior, only a difference in amount of behavior. That is the fundamental difference between normal and abnormal that operates in this sphere that we're investigating. Okay? No difference in kind, only difference in amount of behavior. Now, there is a definition that I have put together for you that encompasses all the major points made by authors and those who study this area of psychology. And although it's not listed anywhere, it's a combination that brings in all the attributes of abnormality. So abnormal describes behavioral, emotional, and cognitive dysfunctions that are unusual and unexpected in their cultural context and usually associated with personal distress or substantial impairment in functioning, sometimes both. All right, now think about that a minute. So abnormality defined first as dysfunction in the way you behave, the way you feel, the way you think. Some combination of those things. In other words, it's not functioning the way it should. It's not functioning well in one or all of those areas. One or more of those areas. So, unexpected in cultural context, and usually, not quite invariably, but usually associated with personal distress and maybe also or substantial impairment in functioning. Okay, so that's a helpful definition to see the various ways that we define this. Okay, all right. Now, disorders themselves are names that we give to collections of symptoms. So symptoms that occur typically together. Okay? And these are observable either as behaviors and or internal mental processes that they would have to tell you about or that you could infer from the way they describe things or the way they speak, the way they interpret reality with their language. So what happens is we also have a sense in most cases of with or without treatment prognosis. So we know if we give people certain kinds of treatment, what will happen versus other kinds of treatment, which may not be as useful. And we know what will happen if they get no treatment on average. No certainties, no 100% certainties, but we have a good sense of what might happen. Okay? Now, there are also thresholds for this mild, moderate, and severe designation that we might give a person with a disorder in terms of the amount of the behavior, the intensity or severity, and then the duration. So remember those things as well, yes? Okay. Now, what causes abnormal behavior? What causes it? Well, as you might expect, most disorders have some combination of biological origins, which include heritable conditions, brain damage, medical conditions, biochemical imbalances, mood-altering substances, mind-altering substances, psychological causes or origins, including trauma, early learning, irrational thinking, and then the group of sociocultural origins and causes, such as troubled relationships, parental neglect or abuse, early learning, discrimination, all of these things. And I want you to, for a moment, look at the things in this list, and this would be slide 43, I think this is, of all the things that a highly functioning society and culture could address. Okay? You look at that list of things and each of those spheres. What could we do as a culture to maximize the chance that these would not be negative influences? You may know this, but the rate of diagnosed psychological disorders in the United States exceeds much of the rest of the world. Now, some of that's driven by substance use disorders, but that's not the only place. Okay. All right. So we take what's called the psychosocial model. And that means, in turn, that all three spheres, the biological, psychological, and sociocultural spheres, interact in various ways to varying degrees. In any one disorder, one or more of those spheres could be the dominant force. We also want to talk for a minute about what's called the diathesis stress model. And that means that if you're at risk for developing a psychological disorder, that when you're under an unusual amount of stress, that disorder was more likely to become expressed. Okay? All right. In the 20th century, a little bit of history here, from say 1946 to 1963, a number of things were published. A book called The Snake Pit, which later was a movie. A book called Asylums by Goffman was published. These were depictions of the horrific conditions in mental health facilities and hospitals. The Hilburton Act, I got that right, Hilburton Act, was funded, which is about community mental health agencies. And then in '63 was the Community Health Services Act. That was designed to deinstitutionalize people and offer them community mental health treatment where they would receive medication and talk therapy, or otherwise receive training in a clubhouse model, for example, where people go during the day treatment kind of thing. In the 70s was when the biggest wave of deinstitutionalization took place, and there was a radical shift away from inpatient, which was socially isolating to individuals, and it was also much more expensive to hold people in hospitals. Well, that was a great set of reasons, but the problem is that until just a short period of time ago, there really wasn't any medications to treat psychosis, the more severe mental disorders. Those came on in the 50s and 60s, and the early ones were beset with side effects that were not good. But they did reduce some of the symptoms like hallucinations. They did work for that, but again, there were many side effects. So there were both economic incentives and individual patient reasons for getting people out of the hospital. But boy, it transferred the responsibilities to areas that couldn't afford it, to the state then, and the federal, and then there was a lot of mixing of funding sources. There was a burgeoning private hospital industry. There are going to be people who fall through the cracks. For example, there are going to be people who don't have transportation or the ability to get to community mental health facilities to get their medications. And it is notorious for people who have psychosis to not trust medication or the people providing them. And of course, people change over time in their severity of the illness. They may get worse, they may get better. In schizophrenia, they may have relapse, they may have periods of time that are lengthy where they're doing okay. So this made for a lot of problems for people who were being seen in community mental health centers. But between around 1960 and around 2001, boy, the number of people who were in mental institutions went from over 500,000 in the United States to 80,000 or so in 2001. Now, some of that is certainly because of better medications and better treatments in general, but we've still got a lot of people who are homeless, who are mentally ill, who fell through these cracks that I'm talking about. So fewer patients are in the hospitals, right? Patients spend less time when they're in the inpatient facility. More patients are rehospitalized. So when they have cycles of severity that increase, where are all the people who are those who used to be in hospitals 100% of the time? Well, they're home. A lot of them are homeless. Some of them are in nursing homes, some of them are in group homes, and an awful lot of them are in jail. So this has been a mixed bag, and a lot of negative things have come from it. 45% of people in federal prisons have some diagnosable mental health condition. 56% in state prisons, and in local jails, 64% of people have a diagnosable mental condition. Because at the local level, they're picking up people who are vagrants, who are breaking and entering, who are stealing, and many of these people have diagnosable mental conditions. And then I think that this video will just basically talk a little bit about the 20th century. I want you to mostly note that the humanistic theories and the behavioral theories and the cognitive behavioral theories all came about really in the 50s, 60s, and 70s. And now cognitive behavioral talk therapy dominates. In terms of research, we can do any number of kinds of research, from experimental to correlational to survey, case study, naturalistic observation. We are looking more at biological ways to evaluate individuals. We look at neurotransmitters and brain imaging and so on. We're looking at genetics and vulnerability and heritability. And we're using more treatment professionals than we did, but it's a mixed bag of competency and training. Clinical psychologists, counseling psychologists, psychiatrists who are medical doctors who do mostly medication treatment, master's level counselors, and then psychiatric nurses as well. I have one slide that talks about these various individuals and their training. I won't discuss it on the PowerPoint. You can on the video. You can look at it on the PowerPoint. It's very dense material, and there's no point in going over it on a video. And then note too that we have managed care, which is our for-profit entities that tell us what we can and can't do with patients. The last thing I talk about in the PowerPoint is an example through time of anorexia nervosa and the way in which we have looked at it as a disorder of asceticism or demon possession. And in the current century, we're really looking at it as a no single cause issue that must be handled at many different levels to treat it effectively. We must have goals for the future that include access, excellence in the providers, and research should be accelerated. See you next time.